top here. All right, and we're live. Cool. So, all right, now we're live. All right, if you're just joining, welcome in. We're gonna hang out here while we wait for people to join. So just wait for, there we go, people rolling in. Welcome. While you're waiting, comment below where you're from. If you're in New Hampshire or Maine, I'd love to kind of see who's in the audience as people start to join us. Let's do some small talk. So Dr. Rose, how was your day today? Was it a busy day? Was it slower?
It was a busy day. It was kind of a lot of following up on patient questions as well as seeing people live and in person. So it was productive.
Nice. Dr. Nard, what about you?
It was a very busy day. Yeah, a lot of new patients, a few follow-ups, some rather difficult patient cases today, but it's part of what we do. So, yeah, no, it was a good day. Yeah.
Nice. That's awesome.
Yeah.
All right, welcome. Thanks for the intros, guys. We got a couple people from Maine. Do we have anyone from New Hampshire who's joining us today? If you're just joining in, we want to comment below where you're from. We'd love to see who's in the audience. We want to make this this one a little bit more involved with the audience, as we're going to be doing some Q&A. So we'd love to. We've got some feedback on my end. We'll look into that, Leah, if you're listening in. So yeah, we want some input from you guys. Be active in the comments. So with that said, let's get right into things. So first question is, well, first let me intro for people who are just joining in. We got more people now. So this is the Med Matrix Method Show. You know, we're excited to have everyone on with us live today. My name is Cole Seifer, one of the co-founders and kind of in charge of patient education, marketing, everything new patient here at the office. Today's episode is going to be a great one because we're joined by two outstanding functional medicine providers. We got Dr. Rose, Dr. Renaud here. Dr. Rose is a naturopathic doctor and acupuncturist with 20 years of experience. She's nationally recognized for her work, digestive health, gut-brain connection, complex chronic conditions. Dr. Rose, I know you do some work advising on the Forbes magazine for natural medicine. And Dr. Renaud, board certified in chiropractic medicine, nutrition, natural medicine, anti-aging, physician assistant. Also, you had your fellowship training, right, in functional medicine with an expertise in hormone optimization, complex chronic conditions, metabolic health, digestive health, autoimmune diseases, Lyme disease. So we got quite the experience here. So we're really going to be diving into two major topics today. We're going to be talking about functional medicine. Why is it different? What can it do for you? And then also a big one, which is long haul COVID, which I know we see a lot of patients in the practice dealing with long haul COVID. So really excited to go deep into these two topics today. If you got questions, hold them to the end. We're going to open up some Q&A at the end. We'd love to hear questions. Thanks everyone for participating. We got people from New Jersey, Cumberland, Portland. Comment below where you're from. Again, we want to hear where you guys are from. So first question, and also just so you guys know, everything here, this is educational. This is not medical advice. All right, we got to say that legally. So Dr. Rose, we'll start with you. Why do so many motivated people still feel stuck or dismissed by traditional healthcare? What's holding them back from getting the care that they want?
Thank you for that question. It's a good one. It's a big one. I think that the system is somewhat broken, and that the way that it is right now is that the visits tend to be between 7 and 10 minutes long when somebody goes to their primary care doctor. I think especially in Maine, there's not enough primary care providers, and a lot of the care is governed by insurance. And so doctors are limited by what they can do by insurance. And it's just people are not being heard, and they're not, sometimes there's dire consequences. And even when they're not, people's well-being and health is suffering because of it. I think it's a systemic thing. I don't think it's individual providers for the most part. I just think it's the way that it's set up that people aren't getting the attention that they need.
Gotcha. So a lot of patients who come to the practice kind of ask, like, why don't you take insurance? They don't understand why it's actually important. So Dr. Renaud, how does insurance actually limit the care, and why is not being constrained by insurance actually really allow us to do different things with patients, or just functional medicine in general?
Insurance is tough, especially depending on the patient's type of insurance they have. Insurance is really difficult nowadays because there's a lot of limitations in what can be ordered. And a lot of insurance companies are tailoring their payment for services or medications or tests based on conventional algorithms, conventional sort of treatment plans that are set by the insurance companies. It's really not by the doctors or healthcare providers. So if the insurance companies don't feel something is medically necessary, they won't pay for it. And unfortunately, insurance coverage is getting less and less, and insurance coverage for certain tests is getting less and less as time goes on. So functional medicine often optimizes testing and methodologies that are beyond the standards that are outlined by certain medical entities or healthcare organizations in the United States. So if it's not in that realm, it's going to be not covered. And even things that are generally accepted, routine mammograms and bone density scans, I see people's insurance like, nope, we're not covering this. And it's like, oh gosh, it's really frustrating. So even routine medical stuff is not being covered, but definitely a lot of the stuff we do in functional medicine is not covered, unfortunately. It should be, because it's preventive healthcare, but it's not.
Okay, going a little off script here. Do you think at some point it would ever be covered? Where do you think the medicine as a whole is going? Do you think at some point, we could see insurance companies paying for the testing we're doing, the length of visits, the time you actually spend preparing for patients?
I don't know. I mean, that's hard to say. I want to be optimistic and say yes, but I also have seen over my career the insurance companies getting less with what they cover. So, like I said, I want to be very optimistic about it. But if the insurance companies could look at healthcare from a preventive lens, right? We'll pay for stuff to help prevent disease. We'll pay for stuff to help prevent heart disease, so we don't have to pay for a patient to have heart disease. That would be great. But that's not the way the insurance company model works. They pay for stuff after it's already happened, right? They'll pay for you to have a heart attack once it's already happened. They'll pay for you to have cancer once it's already happened. They aren't so much interested in paying for healthcare to prevent those things. It would have to be a huge culture shift of the way we practice healthcare in the United States. It would have to be a complete shift of the way healthcare professionals are taught in healthcare schools, whether it's medical school or nurse practitioner school or anything that's involved in traditional medical settings. So it's not just an insurance shift, it's the way healthcare practitioners practice too that would have to change. So I'm hopeful. Yeah. And I see a lot of conventional doctors changing the way they do things because they're frustrated with insurance, but they're learning that well into their years of practice. It's not coming from their education.
Yeah, that makes sense. It's not just the insurance, it's also the way that it's such a deep-seated thing, right? With medical schools, the way they're taught and the way the billing works. So that makes sense. So what's like a tangible difference between functional medicine testing that you guys do on patients routinely versus the testing that you would get at conventional medicine? If you guys both want to answer this, I don't know if you guys have different answers here.
So one thing I also want to add to that, sort of tied to this and to the last question in terms of a difference, is that I think that the way that the conventional medical model is right now, it's all the specialties are so disparate, right? And so, you can think of the primary care doctor as the quarterback, and then there's all these other specialties, and we have people coming in and they're like, my cardiologist doesn't talk to my neurologist, and my primary care doctor sort of, but rarely talks to my neurologist. And so people often just feel like it's so split. And I think we in functional medicine, one of the best aspects of this medicine is that we look at the whole person. And so, we have the time and the visit, and we have the education. And so we see how the whole thing works together. So whether it's like the organ systems are related, right? Like your nervous system is impacted by your digestive system, et cetera. But then also we're just looking at like their mental health, their emotional health, their psychosocial health. Dr. Renaud said something earlier about people with substance abuse, like all of that play, we look at all of that. And I think that's one thing that people are thirsty for. And then just to answer this last question about the testing, we just have such a large toolbox. We have so many tests that we can run, and it goes beyond kind of that standard annual screening test that people get. I'll let Dr. Renaud go into kind of the details, but it's like the blood tests are extensive, the stool tests, the urine tests, the salivary tests. I don't know if you want to go into details on that.
Yeah, Dr. Renaud, what are your top 3 favorite tests to run on patients?
Well, not even specialty tests, but in my experience, just dealing with your average everyday patient that needs help. There are for example, today was a great example. I had a patient who was perimenopausal, very clearly symptomatic of it. She was 42, I think 43. And she talked to her doctor, I think initially about a year ago, and asked, I'm feeling not great. My periods are starting to become irregular. Can you order hormone tests for me? And verbatim, the patient said her doctor's answer was, I don't believe in that. It's like, okay. So it doesn't even have to be, we talk about functional testing and functional medicine, and a lot of what Dr. Rose mentioned are things we do outside of the traditional medical model, like hormone, like advanced gut testing or advanced salivary hormone testing or mitochondrial testing. But even simple things like checking a vitamin D or checking a testosterone in a man over 50 if he's feeling sluggish, or checking hormones for women that are menopausal or perimenopausal. So some of those things are often my favorites because they can give great answers, and they are easier to do, right? It's just a simple blood draw. Insurance will cover some of these tests. It's not a $700 specialty test that we have to run, but the mainstream community, the PCPs, the internists are not doing these tests. Even the specialists are not doing these tests. So Dr. Rose made a good point about patients are getting caught in a network of all their doctors not communicating with each other. And then they're also getting caught in a network of doctors who are so subspecialized in something that unless the patient has that specific problem, well, don't ask me about anything else. The endocrinologist, oh, your thyroid looks okay. Well, my hormones, I don't do that. I don't do, go find, I don't do that. Or I just do diabetes. Well, I don't do that. So, and then it's the patient having to start over, and they call another specialist and, oh, we can get you in 8 months. Oh, well, okay. So it's this vicious cycle of going back to the beginning, right? And then when they try to get with someone, they don't get what they need, and then they're just carted right back to where they started. So it's really tough. Yeah, the testing can be really easily done. That's what we do. Easy tests that we can run, but they're just not run regularly. So
I think a really good example is like the thyroid panel. If people ask their doctor, whether it's primary care, maybe even endocrinology for thyroid, they might get a TSH, a thyroid stimulating hormone. And it seems really difficult for them to get anything beyond that. And I find every day that the fact that in our initial panel, we include free T4, total T4, free T3, thyroid globulin, thyroid peroxidase. It's like just this full panel, even reverse T3, that it really gives this full picture of what's happening in the thyroid and so much more information. And it, like you said, it's not that hard.
No.
But it just seems like it's just not done.
Yeah, and the other thing, Cole, that is a good point, and then we can move on, but a lot of times, and this goes back to the insurance issue, is most providers in the conventional medical space are running labs based on the medications they can give. So Dr. Rose makes a great point that full thyroid panels are not done because when you treat thyroid issues, you don't care what the rest of the panel looks like because your medication intervention only you're only looking at one marker, like a TSH. And as long as the TSH is normal to fit the patient and they're being medically treated with medication, I don't like to say it this way, but their provider might not care how they feel. Their laboratory is normal, and that lab will reflect the medication that's being given. And that's how it's monitored. So they don't go above and beyond because it's not needed based on their medical intervention.
Man, every time I talk to you guys, I feel like I learned so much. It's mind blowing when you hear it, because it's actually like, it's not like functional medicine's like way up here in conventional medicine. It's just like conventional medicine, like it's just the bar sounds pretty low. So it's good to see all you guys are sticking around. Like the views have stayed the same. So if you guys are enjoying this, comment below, let us know, give us a thumbs up. If you've been here since the beginning, you're enjoying this talk, give us a thumbs up. We want to hear your feedback as the show goes on. So please guys, comment. What happens when, you actually start to look at patients as a whole? You do, testing that seems like common sense, like looking at their full thyroid, looking at their sex hormones. What health outcomes become possible for patients when you actually start to, treat the root cause of things and take this more functional approach?
I mean, everything can change. I mean, it can be, you can make small adjustments, you can make large adjustments depending, but it's like, I mean, everything from improved sleep to energy to weight loss to, I mean, I don't know, it's kind of endless, right? The improvements that can be done in my experience.
Yeah.
I mean, it really affects every aspect of somebody's life, I think.
Yeah. I mean, just like the patient I just commented about, she was living a great life, but feeling poorly overall. And it was because she was becoming perimenopausal. And I'm certainly not a woman. I can't say I understand what that's like, but I've treated a lot of menopausal and perimenopausal women, and it completely changes who they are. It changes the way they think. It changes their physical abilities, their physical strength. It changes their sex drive, and that could change their relationship, and it can change self-confidence. And if your cognition is not as sharp because you're in perimenopause, then you might not do your job as well, or you might have to stop doing certain activities that you like to do, or you're tired all the time, so you can't go out with friends. So these are multifaceted interventions that we're making for a person's life, but it might just be hormone optimization. I mean, that's technically one thing, but for a patient, it could change their entire existence, from the way they work to the way they live their life to their intimate relationship to social things. So it can be really life-changing to take a look at a root cause problem for a patient. And that's why we do this work. I mean, I won't speak for you, Dr. Rose, but I'll probably say that that's why you do this. That's why I do this, is to change the outlook of the way people live and the way they live their future and their longevity. So it can be simple sometimes. To us it's simple, but unfortunately to the patient, they're looking for answers for a long time.
Well said.
Yeah.
That was great. So we talked about the difference between conventional testing, and it seems like pretty much just testing the basics, right? It's kind of at minimum what we're doing here. What is like the difference between conventional medicine and functional medicine treatments and solutions look like? Can you explain the contrast there, and maybe even give an example of like one problem, how is treated in conventional versus functional medicine?
I mean, I think really conventional medicine at its worst is just like kind of Band-Aid medicine. And as Dr. Renaud said earlier, it's kind of like you have to have the full-on disease before they even look at you. And we are truly practicing preventive medicine and root cause medicine. And so doing the testing and spending the time to really get thorough health histories, to find out what's really underlying this person's symptoms. And even again, if they're really kind of relatively healthy, but they want to stay that way, we take that seriously too. And how do we maintain that? And if somebody is feeling like they're pretty physically active at age 45, let's do what we can so they're still physically active at 65. So treatments, one thing I really love about this medicine is that it's such a collaboration of lifestyle modifications, education, things that the patient can do on their own, sleep hygiene, nutrient optimization, stress management, exercise, all of that, with this fabulous toolbox that we have, everything from nutraceuticals to peptides to bioidentical hormone replacement. And it's so personalized. And, you can have one person come in who's perimenopausal dealing with insomnia, and you come up with a treatment plan for that person, and it's not going to be the same as the next woman that walks in who's on paper has the same symptoms, but you get to know her and her labs are a little bit different. And so you have other ways to meet her where she's at. So it's creative, it's personalized, and I find it very rich, and it doesn't get boring.
I love the way you say that. Very rich. That's so cool. Do you want me to answer, Cole?
Yeah, let's hear. Yeah, I would love to hear your take on that.
So one thing that I struggle with sometimes day to day when seeing patients is the standard. The best way to look at the standard medical model of healthcare is patients don't understand how sick they are a lot of times. I don't know how many patients in the last 2 weeks I've told are either diabetic or pre-diabetic, and they're what? Like, they're shocked. And it's like, I had no idea, and well, I don't eat a lot of sugar. And it's like, oh my gosh. It's so reductionist, the traditional medical model of healthcare, into, as we were talking about earlier, you have to have some sort of problem for them to take care of you. And so many of our patients have tried even to get help from their doctors, and they're still not getting help, even though they have problems. So the way I try to look at it from a functional medicine perspective is not that we're doing something different, because I don't want us ever to sound, or for me as a professional to sound woo-woo, because people kind of get turned off, like, oh, you're doing like, is this like, is there science behind this and blah, blah, blah. It's like, well, it's not an alternative thing. It's looking at it as, how are we, number one, addressing, as Dr. Rose said, preventive healthcare, addressing issues that are going to prevent people from getting heart disease in many years, but also taking the face value of the patient. People don't understand how unhealthy they are. And the conventional medical system doesn't bring them to task on it. They don't tell them, listen, you eat like crap. You don't sleep well. You don't exercise. It's just, oh, your blood sugar's a little high. Why don't we increase your diabetes medication? Sure, that's fine, but no one is taking patients and really sitting them down and saying, you are not doing the right things for you to exist in a really happy, healthy way long term. And it's very frustrating. So when I can change people's perspectives on that, and they can understand how to live their life in a health proactive way, it's really rewarding, because that's what the conventional medical space does not do. And that goes back to your insurance question, Cole. It does not look at health as a preventive longevity entity. It's really reactive where you have a problem. So when I change people's mindsets about the way they look at their health, it's extremely rewarding.
That's for sure. There's that difference between, conventional medicine being focused on lifespan, so just how long somebody lives, versus health span, like how well you live. So personally, if I'm 98 but I can't really remember a thing, can't move my body, I need help doing everything, I don't really want to be alive. You know what I mean? I'd rather be gone at 75 but doing pretty well up until then. So and even maybe a combination of both would be the best. So it's like, what's the intention, what's the focus?
Yeah, it's a great point.
We're kind of in Sorry,
No,
we got
I was
to
just
stay
gonna.
to the agenda. No, you're
Oh
good.
no, you're good. I was just gonna say, Dr. Rose, how many patients do we see that act like they're 98 but they're like 45?
Oh,
You
too
know,
many.
too many. Exactly. Yeah.
So what type of results could people expect by investing in their health now, doing functional medicine? What type of health returns could they expect in 10, 20, 30 years, even if they're in their 60s, 70s?
I'll let you go first on this one.
I was gonna say, sort of back to what I was alluding to earlier about my patient I saw today that was perimenopausal. I mean, the symptoms she was having was changing the way she had to live her life, and she was having relationship issues, she was having cognitive issues, wasn't able to work as well. So from a day-to-day perspective, it can be life-changing. But then also what we're trying to do, our goal is, as Dr. Rose said a minute ago, is we're trying to improve the way people live in how long they live. So it's not a statistical push forward in the medical world of like, oh, we're getting people to live to be 85. Okay, great. But how well do they live from the age of 50 to 85? Well, if it's poorly, what does that matter, right? There's still a statistic. Oh, they lived to 85, but they didn't live well. So one of the ways I use my profession is to get people to understand how to take care of themselves, number one, because people don't know how. And then also to improve how well they can live past a certain age. I mean, a lot of our patients are of, say, middle or older age, because that's when issues start to set in. And there's this notion, unfortunately, that, oh, well, I'm in my 40s. I know things start to break down. Really? Like I hope not, because that sounds really miserable. So one of my goals with patients is to try to help them see how well they can live for a long time. And it's really about not accepting that health is like a spin of like a roll of a dice, right? Oh, I'm so lucky I didn't get diabetes. Like, that's not how that works. So that's ultimately how I use this healthcare.
Gotcha. So I have a question going right off of that answer. I have a
Yeah.
question for both you guys. So a lot of these common things like IBS, hypothyroidism, hyperthyroidism, pre-diabetes, obviously menopause, right? Something every woman's going to go through. Like, these aren't really complex diseases that have like a 10% chance of solving. Like, how confident, like, for example, Colin, the patient you saw earlier, like, how confident are you that if she does the right lifestyle things and with whatever treatment plan you put together, that like she'll
feel better in a week or two. You turn the light switch on of hormones, even for a man, he'll feel better in a week or two. And then that's the key. And that this is one thing I try to emphasize in all my patients. And I know Dr. Rose does this because I've seen her do it, is if we can just get you a little, like, feeling a little bit better, just like get a little bit of that juice flowing, the motivation and the change in the brain chemistry for a patient really jumpstarts their ability to say, wow, I can do that. Like, I didn't realize how sick and tired I felt. And that's really stinky. So one thing I try to really emphasize is, listen, let's just try to make some simple changes. Once you start feeling a little bit better, we can move mountains. So
that's awesome.
Yeah.
Dr. Rose, what's your take on that as far as like common things like IBS, hypothyroidism, menopause, like
treatment? Well, I think that just to kind of continue that same thread, it's like we've all gone through these periods in life where we're not sleeping well, we're tired, we don't have the energy to eat well, so we stop exercising, and then we feel even worse, and then it's like it all goes together. And so it's like that slight tweak. So maybe it's the hormone optimization, maybe again it's whatever that little piece is enough to give you the energy. So now you can exercise, and then you're exercising, and so then your inflammation goes down. It's like it all perpetuates itself, and it all goes together. I think that the one, maybe a couple questions back, was about like, what changes do we see if somebody can make some changes now? What do we see years later? Wasn't that one of the questions, Cole? Something like that. I think that the hormone optimization is a great example, because if we can catch a woman in her perimenopausal years, late 40s, early 50s, yes, her quality of life today can be such a difference. And there's these amazing preventive benefits of maintaining serum levels of estrogen
Absolutely.
and progesterone and even testosterone. And so we're actually reducing her risk of dementia and cardiovascular disease, and we're improving her bone mineral density. So the way I like to talk to women about it is that maybe you're 45 right now, but if you do this now, this is like a gift to your 65-year-old self, your 75-year-old self. And that's the ultimate preventive medicine. And that's like the ultimate way to have that improved quality of life and well-being, again, in those later years. So yeah, just to answer that question, those are my thoughts.
Great, that was a great answer.
There we go. Okay.
Thank you. Yeah. So, wrapping up on the functional medicine segment before we get into the long haul COVID segment, I got a couple more questions here. First, for people who are, considering to becoming a patient of MedMatrix or any, another functional medicine practice, kind of want to go through each one of the steps and where they might get value. So, Dr. Rose, I'll let you answer this question. What value should people expect to get from just doing their discovery call with MedMatrix?
Yeah, so the discovery call is really like the first contact with a live, real person, and I think it has great value. I think it's really a time when the prospective patient is heard and respected and treated with dignity, and that might sound kind of simplistic, but that's often what people have not been getting. And they have that space, and I know the team, I know the people doing the discovery calls, and they really do care. They really are really great listeners, and they really want to know why are you coming? What's going on with your health? What have you not been getting from your other providers? And they do a really good job of kind of explaining functional medicine and kind of assessing if we can help this person. And so I think what I hear from when I do see the patient and I hear like what their experience was, they feel a connection to the person that they did that discovery call with. And I just think there's so much value in that. And for a lot of people, it's the first time that anybody is explaining functional medicine and answering questions about functional medicine. And it's not just what they've seen on social media. And that's big. I think I feel like we all have this mission to just spread this information as much as possible. So to have such a good team be able to explain it well is of great value.
That's awesome. Thank you. Yeah, I would agree with you. The team here is something special. So what about the initial testing? So after the discovery call, patients come in, they do a whole bunch of blood work, probably a lot of which they've never done before. Dr. Renaud, what can patients expect? What value can they get away from just that initial blood work?
Well, the initial blood work is really important because it guides us on what we can do with the patient to get them started on a treatment plan. A lot of times when you're seeing your doctor, you're waiting a long time, and even if it's a specialist, you're waiting a long time to even see them. And when you go to see them, nothing has been done. It's like, oh, well, you need some tests, you need some blood work, and then it just extends the time. So the way our methodology, not only are we testing for things that are not routinely tested in patients that are really invaluable, is we're getting some tests ahead of time. So when myself or Dr. Rose or other of our colleagues that work at MedMatrix, when we see patients for the first time, we have a blueprint to go off of. And it's not just a session of you telling me what's wrong with you and then, oh, well, we got to wait, we got to do some more stuff. It's very proactive. We are ready to go from the first day. We can get people started on their very first treatment or their very first appointment. So the blood work really sets the tone of treatment. And then also it's so comprehensive in what we're doing. We're assessing cardiac risk function. We're assessing hormone dysfunction. We're assessing thyroid issues. We're assessing nutrient levels. So these are things, as we commented on earlier, that are just not done routinely by anyone in the medical system. And, it goes beyond the traditional CBC by their PCP and like, oh yeah, my CBC is normal, so I'm healthy. Who came up with that? Like whoever came up with that notion, it's just so reductionist. So the amount of value that we have from the testing is really, really priceless, because we're like we've said before, looking at whether they have heart disease risk, whether they have stroke risk, whether they are hormonally deficient, which could affect bone mineral density, which could affect all these other things. So there's so much data that we're gathering about the different metrics of the patient, and it's really invaluable from the very beginning. So we find it extremely important.
Well said. Thank you. All right. So that is going to wrap up the functional medicine segment. If you guys have questions you want answered, we're going to do some at the end, but we got to get into long haul COVID, talk a little bit about the COVID vaccine. I know a lot of people have questions about that. Real quick, for patients who are joining us, for new patients, there is kind of like a little special, if you will. If you're seeing us live, you can actually, there's a link that was just posted in the comments where you can book a discovery call and get $200 credit as a new patient. So if you want to do that, go ahead and do that. With that said, we're going to roll right into long haul COVID. So I'll get this from both you guys. What is long haul COVID? The term's kind of thrown around a lot now. Like common questions are, can it be caused from the vaccine? Like what is the root cause issue of long haul COVID? I'll let both you guys answer. Dr. Rose, if you want to go first.
So I think technically it's when, symptoms persist. So you say you have an acute infection of COVID and they persist greater than 4 weeks. Some of the research studies define it a little bit longer. Excuse me, like you've had, it's been 12 weeks since your active infection, and that's considered long COVID or long haul COVID. But the symptoms are multi-systemic, right? Like it can affect respiratory system, nervous system, even digestive system. And so kind of like a lot of these other chronic, somewhat degenerative, I guess, diseases, we see debilitating fatigue. We can see heart palpitations, shortness of breath, chronic headaches. I mean, Dr. Renaud, I'll let you get into more of the specifics, but it really can affect so much of a person, and it's a clinical diagnosis. There's not like a test. Oh, you have long COVID. I hear, right. I see it in your blood work.
Yeah, and that's something we can answer. I know Cole wants to talk about that too, is testing specifics, but the symptoms can be very multi-systemic, and oftentimes it's misunderstood from patients or their practitioners, because their acute COVID infection could look like a very acute upper respiratory-like infection, right? Like you have a COVID, I have a fever, I don't feel good, I have flu-like symptoms, whatever. But then once the COVID goes away, their symptoms can persist, or maybe there's a reprieve there, but symptoms can start to persist, as Dr. Rose was saying, where we're getting fatigue, we're getting brain fog, we're getting shortness of breath, headaches, chest pain, heart palpitations. So these symptoms may not align with what they experienced during the active COVID infection. So the patient starts to get a little bit confused as to, well, I had COVID a month ago, but like I'm tired all the time now, or my joints hurt, I'm having these heart palpitations. So they see their doctor, and then the doctor sends them the cardiologist or the pulmonologist, or so it can, even the diagnostics or figuring out they have long COVID can take a while, because the patient might not know, or their doctors don't know. So it really is the emphasis of long COVID is it's a multi-systemic problem. And the causes are also very varied. And I don't know, Cole, if we want to get into that, but it's certainly a very interesting topic on how this happens and why. But it's a very persistent issue now, post-pandemic.
Yeah, we heard a lot from, I guess, how many patients are you guys seeing who might have long haul COVID, who believe they're struggling with long haul COVID? Because I know the patient coordinator team hears it all the time.
Yeah.
I mean, I think we see a number of people who the patient themselves questions it, they're wondering. And then I think because these symptoms can be so many things, and I will probably get into how it can overlap with autoimmune conditions, with dysautonomia or POTS, like it can, other inflammatory conditions, it can be very confusing. And I think people, even if the patient doesn't come in making that connection, I think part of our questioning is, did you have a COVID infection? Even did you have a COVID vaccine? What was the timing? When did you start feeling poorly? And kind of try to go back in time and piece those together. So I think it's probably more common than anybody even realizes. At least the way that I see it is like, people will often have these underlying issues, right? Again, maybe an autoimmune condition or maybe another inflammatory condition, and then they get a COVID infection, and it's like the final straw. Or kind of like, it kind of unmasks some of these underlying things that they were maybe able to kind of ignore, push aside, just kind of like deal with, and then they get COVID, and you just can't just deal anymore. Like they're almost debilitated, right? Like they can't work. They can't, I mean, we've probably seen, both of us have probably seen a whole range of how debilitating it can be. So it's a lot. And sometimes the patient has connected it to COVID, and sometimes they haven't.
So what's actually going down like under their skin? Is it, because you hear spike proteins, like what is actually causing? It's like spike proteins, inflammation, all these kind of buzzwords. Like what is the issue of long haul COVID?
So long haul COVID, there's many suspected pathophysiologies, but some of the things that we suspect that are going on is one thing that we talk about a lot is endothelial dysfunction with long haul COVID. The endothelium is the tissue that forms like a single layer that lines the inside of your blood vessels or organs or cavities in the body, the lymph system. And what happens is this endothelium, this tissue, can become dysfunctional, which when combined with inflammation in the body can activate clotting pathways. So people's blood is kind of too thick, and we call it microclots or hypercoagulable blood, where it's almost like if you haven't changed your oil in your car for too long. You know, oil is supposed to be nice and liquidy. If your oil is old and sludgy, it's not going to make your car run very well. So same thing with blood. If there's inflammation, if there's all these microclots floating around, it can make the blood very, very thick, and you're not perfusing blood in the microcapillaries of the body, the brain, the skin, certain organs. So that's a part of the pathophysiology of long COVID. You also mentioned the spike protein, Cole. For people that don't know, what the spike protein is, the protein of the coronavirus or COVID that mediates the virus's entry into the host or the cell of the human. So we've seen in some post-mortem studies of people that died of COVID, especially when it was the height of COVID years ago, that this protein is embedding itself in people's tissues, in their gut, in their heart tissues. So what we're thinking is that this protein, while the infection is over, it has passed, the protein is staying around and invaginating itself into the soft tissues of the body, and it's creating this hyper inflamed state and this immune system response that's constant. You know, it's almost like fighting off an infection 24 hours a day times X number of times. So the pathophysiology is very complex. And Dr. Rose made a very good point to say that a lot of people, especially that I've seen, and I'm sure she has as well, we've both dealt with very complex chronic illness in our careers, that a lot of these people that do get long COVID have had some sort of issue in the past, right? Was their health tip top notch when they got COVID? Probably not, right? Maybe they had a gut issue. Maybe they had an underlying immune dysfunction, some sort of infection issue that was undiagnosed, like Lyme disease or a co-infection of Lyme. So we see a lot of complex comorbidities in patients with long COVID. And oftentimes, as Dr. Rose said, it's the tipping point. COVID just brought them, they were at the edge of the cliff, and COVID just pushed them over. So we see that a lot, unfortunately. But I have seen patients, I have had a couple patients in my career that were tip-top athletes. Nothing wrong with them. They got COVID and it ruined their life. So what's going on in those people? It's very complex.
So what happened to those patients? Like if you have COVID, you have long haul COVID, are you just screwed, or like what can you do about it?
Do you want to answer that, Dr. Rose? You want to go first?
I'll let you go first on this one.
Okay.
I'll answer.
No, you're not screwed. You're certainly not screwed. But in all honesty, the opinion of long haul COVID is gonna depend on the provider that you see, right? There are some practitioners out there that are of certain specialty, whether it's in the alternative medicine world or conventional medicine world, and they're going to treat you very differently depending on what they know to be true. So long haul COVID, while there are a lot of comorbidity issues involved in patients with long haul COVID, I treat them the same. I look at all the same things that I would look at for any other patient, right? What's their gut health doing? What's their nutrition doing? What are their hormones doing? And sometimes it's not that easy, right? Patients that have long haul COVID, I have treated a lot of patients with complex chronic issues post COVID that are medically disabled from it. They can't work, they're homebound. It can ruin their life. And I'm not trying to scare patients or anybody listening, but it can be very serious. So from a diagnostic perspective, I'm trying really hard to look at the patient the same way I would look at any other patient. How do we optimize? What's going on? What are root cause issues? What kind of medical history do you have? Have you ever had Lyme disease? Have you ever had, symptoms of immune dysfunction? So what's your gut health? There's always ways to optimize. So that's a good place that I always start if things are not blatantly obvious. But you also have to try to help people regain function. And that can be difficult in the initial phase, but sometimes it can take very simple steps, like nutrition optimization or other things to help their baseline foundation get better.
I think that's big. I think that baseline foundation is really big. Like, what is gut health, right? Like, what are the bowel movements like? Is the liver kind of detoxing appropriately? Are your kidneys, your liver, is that optimized or not? And just some of those basic things, like if those are out of balance, then it's going to be really hard for that individual to feel better and to basically get past what they're dealing with.
Stress hormone.
Stress. Yeah, that's a big one.
That's a big one. Yeah.
Gotcha. So what, I'm sure a lot of people would love to hear, like, what does a treatment protocol look like? Well, I guess first, let's start with some context. What does a treatment for long haul COVID look like in functional medicine versus traditional medicine?
Ooh.
I don't really know what traditional medicine is doing. I can answer a little bit more about what some things that we can offer. Well, we've kind of started to, right? So, giving somebody some things so that they're having regular bowel movements, giving them, a nutrition plan that is anti-inflammatory, that is not going to kind of exacerbate things, but that's actually going to heal things. Looking at cortisol levels and stress management, and giving them, whether it's nutraceuticals, botanicals, other things that are basically going to support the nervous system. This is physiologic stress that they're going. They might be mentally stressed in their life, but just having long COVID is just a physiologic stressor on the body. So how do we support the adrenal glands? How do we support the nervous system? It could be anything from botanicals to peptides. There might be a hormonal imbalance. So looking at that. And there's, in terms of just kind of overall, like reducing inflammation, there's just so many tools, right? There's low dose naltrexone. There's, again, other peptides. There's, various forms of an anti-inflammatory diet. And then you have all the nutraceuticals, everything from omega-3 fatty acids to, the right amount of turmeric every day. So figuring out what works for that person. And I always think it's also important not to overwhelm them either, right? So maybe starting with a few things and letting them kind of, incorporate that into their daily regimen before you then go to the next level.
Yeah, healing is not a overnight thing.
Right, especially with anything chronic.
Do you have like a case study example? Like, how did you, like these athletes you had who came to you whose lives were ruined from long haul COVID? How did you?
It's.
I imagine
tough.
you care, right? So how did you help them?
Yeah. Well, I can speak to some of the medical piece first. If you go on like Cleveland Clinic's website, a lot of what they're advertising for their long haul COVID patients are antidepressants, therapy, and anti-inflammatory drugs. So, okay, does that solve any problems? I don't know that it does. And there's a lot of some people I know that are in the long haul COVID community, the medical community. They're doing studies on different drugs, the different antivirals, different immunomodulators. There's patients that are being given anticoagulant therapy with HIV drugs to help reduce the inflammation and the hypercoagulopathy in the blood, to help patients. But my big question is, well, what do you do then after? Like, then what? It's sort of, I appreciate the medical system's attempt at trying to understand this from a health, public health perspective, but it's the same approach. Well, we have to find the right drug. Really? Is that going to be the answer? So I don't think the medical community is doing a great job of it, but some of my elite patients that I've had that are struggling with long COVID, a lot of times, in my opinion, the way that they got there is a bit of the opposite of what most of our patients are dealing with. So most of our patients that we see are not living a healthy lifestyle. They're not eating well. They're not exercising, right? They're kind of doing very minimal. Some of my patients that have had long COVID issues that were of elite status were probably doing too much. So they were burnt out. They had no cortisol. They're burning the candle at both ends. So if you are an overperformer, you are, in my opinion, just as at risk of long-term health complication than an underperformer. Because if you don't take care of your body, if you're not allowing yourself time to heal, if you're a really hardcore CrossFit athlete, triathlon, whatever, and you're not giving yourself the tools you need to heal and to allow your body that healing ability and that healing time, you're going to burn yourself out. And then you're not going to have the reserves to get better when you do get sick. And that's what I've seen. So patients that need help that are of elite status that get sick, they need to dial it back. So I often try to have to teach them how to heal and how to do less, if that makes sense.
Totally. Yeah. Really good stuff. Real quick, for everyone who's in the chat, we're coming up on time here. So if you have questions, we're going to start rolling into Q&A in a second. So if you have questions, start dropping them in the chat. If you've been here since the beginning, let us know. Tell us. We'd love to see who stuck around. So start getting those comments going. You said something in 30 seconds or less, because you said something that was really interesting. You mentioned the link of cortisol and your cortisol being drained and long haul COVID and just disease in general. What's the link between cortisol and your immunity, if I'm saying that right?
You are. I mean, cortisol is one of our basic stress hormones that mediates our stress response and also helps regulate your sleep cycle. So your cortisol is what keeps you going, right? It's part of your fuel, amongst other things. Hormones and nutrition are part of your fuel, but your cortisol is what is regulating your body's ability to handle stressors, physical stress, physiological stress, emotional, mental, whatever it is. So if you have overexerted your physical or mental self, so physically, training too hard, overexerting, working out 4 hours a day in the gym and not resting, or also one other example of overworked cortisol is people with trauma history, sexual, physical, interrelationship trauma, a car accident, some sort of physical or emotional trauma. They have run out of the body is just like, it's done. It doesn't have the ability to recover. Their cortisol is just run out. It's almost like they've run out of gas. So when that happens, what starts to occur is the body's ability to maintain homeostasis gets thrown off. So the immune system could become too overreactive or too slow. The immune system can often overreact to something that is totally innocuous. Dr. Rose and I have some experience treating mast cell activation syndrome. We see this a lot where the immune system just becomes too overactive and too sensitive to the world. So the cortisol plays a huge role in that. And it's really important to understand what your limits are and understand how to feel how to fuel your body when it needs it.
Gotcha. Dr. Rose, do you have a take on that?
I just want to speak to the cortisol piece because this comes up almost every day when I'm going over people's blood work, which again, our initial panel includes cortisol levels. Sometimes it'll come back as low and people say, why is my cortisol low? I'm so stressed. Isn't it high cortisol? So I think it's really important to know that there's like these different stages of what we call like adrenal fatigue and cortisol dysregulation. So if somebody is in fight or flight mode most of the time, and this applies to children, this applies, as Dr. Renaud said, like with trauma, your cortisol is going to run high all the time. And it's really not supposed to run high all the time. It's supposed to spike in the morning and then drop and then be at its lowest at midnight. So one type of adrenal fatigue is that elevated cortisol all the time, not dropping when it's supposed to at night. And then there's the dysregulation where it's high when it's supposed to be low, low when it's supposed to be high. And that's when people's energy levels are just fluctuating all the time. They can't go to sleep at night, but they can't get out of bed in the morning. And then you have, when this has been going on for years, this kind of cortisol dysregulation, this fight or flight mode. They're in sympathetic overdrive. That's often when we'll see the flat line, right? They just are not getting that morning peak, that morning cortisol peak. And so that's sometimes what we're seeing on that initial blood work, is that the cortisol is too low. They still feel really stressed, but the adrenal glands, they just can't push out any more. It's like the gas tank is just kind of empty. So at various stages of that, but maybe especially when it's kind of at this dysregulated stage, that's when there's that immune vulnerability. We really do need to recover. We really need to kind of get into that relaxation mode and maybe dial it back, whether it's from your exercise regimen or other things, in order to, just to use the same analogy, kind of fill up the gas tank.
Yeah. Okay. Every time. Yeah. Like I said, it's always so eye-opening talking to you guys. I wish we had unlimited time to talk, but we're running out of time here. And I got one more question left, and this is a pretty controversial one, just around, COVID and the vaccine. Does the COVID vaccine, can it cause long haul COVID? And if so, how? You're both shaking your head. Okay. So why?
Yes.
Dr. Ard,
simple answer is yes.
Okay. Why don't you go first? Can you explain?
The simple answer is yes. I've seen that clinically many times. So we approach it a very similar way, where, okay, there's been this assault on the body. And I use that not disparagingly, but an assault is just something was put in the body and it shook things up, and now the body's dysregulated. So it's the same sort of thing as an acute illness of COVID, right? There was an assault on the body's got to respond, the body's got to recover. A vaccine has, things that are in it that the body needs to process and detoxify, and you've got your immune system has to be functioning properly for you to process what is being given to you. So I have seen a lot of long haul COVID issues post-vaccine. I've seen people have heart attacks post-vaccine. Are they connected? Not sure. It was the day after. Does that matter? Don't know. So there are a lot of things to consider with the vaccination. And one thing I try to educate patients on, because I'm certainly not anti-vax, and I know us as an entity at MedMatrix, we're not anti-vax. We try to understand the best for patients. But when I always try to educate patients on things with regard to vaccines, is the patient ready for it? How do we support their immune system? How do we support their physiology so that the vaccine can be taken by the person in the best way?
Gotcha. Dr. Rose, what's your take on that?
Yeah, I mean, I've seen it happen. I have a family member that it happened. It kind of, for him, he didn't have COVID, but he had the vaccine. And then for him, it kind of unmasked chronic Lyme. So really wasn't suffering from back pain, shoulder pain until that COVID vaccine. And really it was like that's what testing revealed, was kind of, a Lyme infection, a tick-borne infection from years prior. So I know it can happen, and I think it's that it can trigger that same inflammatory response. It can, I have seen it, and I don't know how common it is. I think that in general, the vaccine in general is going to reduce somebody's risk of getting COVID. And there's more of a chance of somebody getting long COVID from actually having the disease, not the vaccine, but that doesn't discount the number of cases where the trigger was the vaccine.
And is this way for treating, you know, an injury or long haul COVID from the vaccine the same way as treating long haul COVID as if they just got COVID?
In my experience, yes.
Yeah.
Okay,
Definitely.
gotcha. All right, well, that's time. I see someone say chronic Lyme disease. I may have said that by accident. I was talking about COVID. We will certainly do, you know, maybe a segment on Lyme disease in the future. I know in Maine we see a lot of patients here with Lyme disease. So if you're just joining us or you've been here for the whole chat, drop a thumbs up or, you know, your favorite emoji if you've been enjoying this, so we know to do more or less of these, because you guys are hating this. Maybe we should stop. But if you guys are liking this, let's do more. So give us a thumbs up, and also drop some comments, because we're going to do Q&A for just a short little bit here. We'll see how many questions we can get in before the doctor's got to bounce. But yeah, let us know how you guys are doing. So first question is, if a patient has objective symptoms of hyperthyroidism and perimenopause symptoms and the lab work to support those findings, what's the general first step approach? So I imagine this patient saying, okay, female comes in, hyperthyroidism, perimenopause in the labs. What are you guys doing from here?
Is it hyper or hypo?
I think hyper.
Sorry, hypo. That's important. Yeah.
A little more common.
Yeah.
A lot more common.
Okay.
So
Dr. Rose, why don't you go first?
The question is, what are we doing about it?
Yeah. So patient comes in, hypothyroidism, perimenopause, that you can see from the lab work. What are you? What's their general plan of action from there?
So sometimes people come in like that and they maybe already have some kind of hypothyroid diagnosis. They had a partial thyroidectomy. They, you know, and it's either or we are the first to diagnose it. So really looking at the big picture, looking at how, you know, sex hormones interplay with thyroid, and again, everything from nutrition. There's certain foods that you kind of want to avoid. If it's an autoimmune form of hypothyroidism, I usually recommend people minimize or eliminate gluten from the diet. And then there's some things that you do want to eat. You want to eat a lot of Brazil nuts, which are high in selenium. That kind of feeds the thyroid. So little kind of tidbits like that. And then we might, you know, there's some botanicals that can support the thyroid. There might be thyroid replacement therapy if that seems like the right route. And there's even options with that, right? There's kind of natural thyroid. There's synthetic thyroid replacement. And I kind of think of it as a menu, and we're here to lay out the items on the menu. We're not like attached to one. We're just wanting to educate and provide information and let the person be empowered in making those choices for themselves. And I'll let you, Dr. Renaud, talk about maybe the sex hormone piece, the perimenopausal piece.
Yeah, I can speak to it really quick. Most of my women, either in perimenopause or postmenopausal, almost every single one, when I go through their labs, their thyroid is suboptimal, and it's definitely hypo, as we clarified. Hyper, I don't see very much, but in my experience, when women are in some form of menopause, the thyroid just starts to become dysfunctional. It gets just a little slow. So when we correct and support the hormone piece, the sex hormones and the menopause, the thyroid often bounces back. And we still support the thyroid, as Dr. Rose said. We can optimize the nutrition, certain nutrients that we give to help thyroid hormone conversion. But in my experience, when the perimenopause and the hormonal dysfunction is corrected, the thyroid often follows. I usually don't start by treating a thyroid issue in a woman without ignoring the hormonal dysfunction. That's very rarely would I do that.
Okay, gotcha. So moving on to the next one, we got to go through these pretty quick here. So try to be as value condensed as possible. You guys have so much knowledge to share. So real quick, let's see. As someone who lives out of state, how much of this treatment work can be done remotely through televisits, testing in state? So you do have to be in Maine and New Hampshire for us to legally see you because of the licenses. Now we can't do telehealth. You would have to be in person for the initial appointment where we do some of that testing. I just put a link in the chat for you. If you guys are watching us on the webinar, if you click that link, you can actually get $200 credit towards any initial testing you would do with us. So if you're interested in becoming a patient, want to talk to a coordinator, click that link. Whoever made that comment, I would recommend just clicking that link, speaking to a coordinator, seeing if we can help you out. All right, medical question. Hi, long haul COVID patient here. When getting treated, are patients treated by both doctors, as in you guys have access to both Dr. Rose and Dr. Nart, or would it be a primary provider? So how do you guys, that's actually an interesting question. So I know, so you do have your assigned provider, but how do you guys work together, right? So yeah,
I mean, all of us providers within the practice, we can coordinate amongst each other with cases if we're struggling. When patients do join the practice, they are assigned a provider. And if there's a provider that the patient has researched on their own that they feel would be most appropriate for them, they could certainly see that person. But generally the patient doesn't see multiple providers within the practice. That makes it a little difficult to provide adequate care when there's too many cooks in the kitchen. But we certainly do a good job of talking to each other when we're struggling with complex cases or just case review, like, hey, can I get your thoughts on this? So we do coordinate a lot.
Absolutely. There's 3 other providers also who are not on this podcast. And so there really is kind of a wealth of knowledge. And we're all, if somebody is having, again, a question about a case or something, usually that question will go out to all of us. And so anybody and everybody can kind of chime in.
Yep.
Great. Okay, cool. Next one. Should I take anti-inflammatory if blood work just showed high level of inflammation? PCP doesn't know what to do. Again, none of this is medical advice, guys. This is all for educational purposes. With that said, yeah, what do you guys think on that?
The question, the inflammation levels are elevated or not elevated?
Should I take anti-inflammatory medications if blood work just showed high level of inflammation?
I mean, you can, but there's just so many other ways to lower inflammation other than kind of your classic anti-inflammatories or NSAIDs. So again, it comes back to that large toolbox that there's, whether it's nutrition or other things that kind of can get to the root a little bit more than just masking.
Yeah, my answer to that is, when's the last time I prescribed an anti-inflammatory medication? I don't really remember. So that'll be my answer. Yeah.
Okay, good answer. Let's see, picking the next one here. Okay, other than elevate your lower leg or wear a compression sock, there does not seem to be anything further for edema, swelling of the lower leg and ankle. Do you have any ideas to cure edema?
Oh,
I don't know if this is, I feel like that's maybe a little more of an in-depth personal question. I don't know how on topic that is.
Yeah. Edema is very multifaceted. Can be a heart problem, can be a lung problem, can be an obesity problem. That's a little hard to answer. Okay.
Vaguely though, like something like edema, how do you approach it? Because there are other diseases like edema that, I know you guys see pretty often. Is the approach there more to like there's something acute that you're trying to find at the root cause, or is it more like you're just trying to optimize everything's in this person's health and allow the body to heal on its own? What's your approach with
acute edema? Is usually some sort of an infectious process. Chronic edema is not acute. There's something wrong that's persisted for a long time. Is it related to obesity? Is it related to diabetes? Is it related to heart failure? Is it related to a pulmonary problem? Same approach. Got to understand the body's physiology better.
Gotcha. Okay. Yeah. My labs are normal according to doctors, but chronically fatigued. I know we hear that.
Every day, all day. Yeah.
Yeah. We don't have enough time for that. Yeah. That's everything we've talked about in a nutshell, from nutrition to diet, to their lifestyle, to their hormones, to their thyroid, to everything, their stress hormones. Fatigue is the most lengthy differential diagnosis symptom. One of the most. So it could be any or all the above.
Yeah.
Yeah.
I think probably 8 out of 10 people that come in are fatigued.
Yeah. Yeah.
Gotcha. Okay. Hey, real quick, I saw someone say the link isn't working for the new patient. I just tried and copy and pasted it again. So try that link. Maybe that one will work better for you. It's the same one, but maybe I missed a letter or something. Hey, how much time do you guys have left? We got a ton of questions in here, but I also know we're like 8 minutes over. So where are you guys at?
I'm okay.
A couple more, 5 more minutes, maybe.
Yeah.
Okay. We'll do 5 more minutes. If you got questions, make sure you're dropping them in. Love the action here. So do you have treatments or plans for people with Ehlers-Danlos, EDS, or POTS, or MCAS, which I know you guys were talking about earlier? So EDS, Ehlers-Danlos syndrome, POTS, or MCAS?
I know the answer is yes for both of us, and I would actually love to do a podcast just
Yeah,
on
we need
that.
a separate discussion on that.
Okay.
It's big,
Yeah, stay
and
tuned.
it does tie in with long COVID. I mean, those are
Yes.
often kind of, again, unmasked maybe by long COVID, but I would love to dive deeper into that one with Dr. Renaud specifically.
Yeah, that's a whole nother, that's like a book we could write. That's not a short answer.
Okay.
But yes, the answer is yes, we do have treatment options. Lots.
Awesome. Oh, cool. We got a little testimonial in here. My labs were so eye-opening, and I met with Dr. Renaud 3 weeks ago, plan in place, and I'm already seeing so many positives. Looking forward to my next labs visit to see the progress. We love it.
Great.
Thank you.
Congrats.
great.
Can't wait. That's awesome.
Thank you. Okay. Guys, when commenting questions, try not to make it like medical advice. So for example, should I take antidepressant to help with long COVID fatigue?
Well, we can't answer that, Cole.
Yeah, that's
Yeah.
what I'm telling people. So try to make it more vague. We can't be giving you guys medical advice on this. So let's see. All right, guys, we're gonna wrap it there. I think it's a good one to end on, a little testimonial. If
Awesome.
it looks like the link isn't working to book a discovery call with our patient coordinator team, super sorry about that. We'll have to figure out why. The link's working for me when I type it in. But if you want to get started with us as a patient, just go to medmatrixusa.com and click get started. And then, yeah, we love, talk to the patient coordinator team, get you in for some labs, and get you a plan in place for your health. Where do I find you in NH? The main clinic's in Portland, and then we would do telehealth for you in New Hampshire. We do have a small satellite office in North Conway. But other than that, thank you everyone so much for joining. We're going to be sending out a recording of this if you want to watch it back. But yeah, Dr. Rose, Dr. Renaud, thank you so much for your time. Anything you guys want to add before we head out?
No, that was great.
No, it was great. Yeah, stay tuned for more good conversation. Yeah.
Awesome. Thank you, everyone. Bye.
Thank you, Cole.
Bye-bye.
Bye.